Dear friends, we have seen in the previous chapter that there are several kinds of retinal detachments, even though they may seem similar. It is true that a dialysis at the ora serrata can look like a giant tear. But in my statistic, the risk of failure for a giant tear is 35 times greater than for dialysis. We have also seen that the natural history of a standard detachment can show degrees of evolution and therefore of gravity, ranging easily from 1 to 10. This is why it seems unreasonable to propose the same strategy for all these detachments. And moreover, as we saw in the first chapter, no statistic, even the most serious, has ever shown the superiority of a systematic surgical technique, and in particular the superiority of vitrectomy over indentation, even in the only contexts of stage A detachment. In order to try to see more clearly, it was therefore necessary to organize a very large study, not only to study the best strategy according to the different stages, but also to study the influence for each stage of different variables, whether semiological or technical. I organized therefore in 2011 the EVRS Retinal Detachment Study, the largest global statistic ever made on the subject. 7,678 regmatogenous retinal detachments, more than 11 times more cases than in the SPR study, all primary procedure, stage 0, A, B, and C1, and addressed by 180 surgeons from 48 countries. The number of cases, countries, of doctors working in public or in private institutions and using different machines made it possible to reduce the statistical bias. And this is even more important since it was not a randomized study. Example of bias, countries. It is clear that the distribution of PVR cases collected for patients operated on in Algeria or in Malaysia does not reflect reality. Similarly, two doctors from the same country, Italy, with very comparable annual activity may have different recruitments, explaining their completely different severity cases. This is why this study is so interesting, because this huge number of cases makes it possible to cancel all of these statistical bias. Each doctor had to fill in 30 different variables. Data scientists had to clean the sheets to make them interpretable. Thus, only 18 variables could be studied, 7 on clinical findings, 3 on vitrectomy parameters, 3 on endocular maneuvers, and 4 on external procedures. 3 levels of failure have been identified. In red, the complete failure, declared by the surgeon, no more chance of recovering even the smallest vision. In orange, the cases where the silicone oil could not be removed, suggesting that the future of the vision is very uncertain. Finally, in yellow, the cases where reoperations for complication or recurrence were necessary. An univariate and bivariate analysis of the entire database allowed to identify the variables having a relationship with the failure rate. Then, a multivariate study identified the variables that affected the failure rate independently and allowed to build a surgical strategy after more than 3,000 lines of calculation. The only disadvantage of this study, and I say studies because this is also the disadvantage of all the multicentric studies, as I mentioned in chapter 1, is its lack of homogeneity, both in the clinical detail recognition, because we don't have the same way of examining our patient, as in the technical realization. There are 100 different ways of performing a backlink depending on the material used or the suturing technique, and maybe even more to do a vitrectomy. This study must therefore be taken as a very exact reflection that a standard technique can give for a precise detachment. Each of us, with our own semiological analysis and technical tips, can escape the strategic rules of this study, but we must keep in mind certain fundamental principles that emerge from this study. Well, let's start and see the results. I warn you, it will be long and can be tedious, but the brave will discover so many teaching lessons. Let's start with the influence of clinical details. And first, according to the PVR. As you would expect, the more the PVR is developed, the higher the failure, either complete failures or cases where the silicone oil had not been removed. For complete failures, there is no significant difference between stage 0 and A or between stage A and B, but there is a difference between stage 0 and B. The success rate after a single surgery reaches 83% for stage 0 and drops down to 63% for stage C1. Among these 7,678 detachments, aggravating factors have been found, and their presence seems to worsen the final failure rate. For example, the presence of a large hypotonia seems to cause 3 times more failure. The problem is that cases with aggravating factors have more severe PVR. For example, more than half of the eyes with a choroidal detachment develop PVR B or C1, while they are present in less than a third of normal cases. We therefore analyzed the influence of these aggravating factors at each stage of PVR. It then appeared that the vitreous hemorrhage is not independently linked to the failure risk. On the other hand, the presence of hypotonia and especially of choroidal detachment, which causes 20 times more failures at stage 0 and 10 times more at stage A and B, are both variables independently linked to failure. When we group together the choroidal detachment and hypotonia, we see that the difference is significant for each stage of PVR, both for complete failure, except for stage A, and for the persistence of silicone, whatever the stage. Multivariate analysis confirmed that hypotonia and choroidal detachment are independently explanatory variables of failure rate. This result confirms the work with the laser self-limiter which I mentioned in the previous chapter, reinforcing the idea that we have all more or less in mind, that hypotonia is a poor prognosis factor, but that we had maybe a little forgotten. And if we now return to PVR, excluding the impact of choroidal detachment and hypotonia, this correlation between stage and failure is maintained, especially for stage C1, which the multivariate analysis has designed as a variable independently related to failure. Now let's see if the crystalline status has an impact on the failure rate. A priori, when we look at the distribution according to the type of tear in phakic, pseudophakic or aphakic eyes, the same proportion and the same number of tears are found. On the other hand, the aphakic has more detached quadrants than the pseudophakic, which itself has more detached quadrants than the phakic. Similarly, the aphakic are more severe cases than the pseudophakic, who themselves are more severe cases than the phakic. So, if we look at what happened according to the stage of PVR and excluding the impact of hypotonia and choroidal detachment, we see that there is no significant difference concerning the complete failure rate. Certainly, in pseudophakic eyes, there remains a higher rate of persistent silicone oil, but this is linked to the fact that many more vitrectomies are performed in pseudophakic eyes, therefore more injected silicone. But in total, the univariate or bivariate study, as well as the multivariate logistic regression, showed that the lens statute is not an independent explanatory variable of failure. As for the number of detached quadrants, their numbers seem correlated by an increase in the number of retinal dehiscences, by the number of aggravating factors, as well as by the severity in terms of PVR. But if we analyze at an equal PVR stage and excluding the impact of hypotonia and choroidal detachment, the influence of the number of detached quadrants does not appear obvious. Now let's talk about the influence on the final results of the different type of dehiscence. And of course, in the case of multiple dehiscences, the worst of them. We see immediately what I told you about earlier. Some of us have trouble analyzing clinical details, which may seem normal when we know that they are not taught much anymore. How could so many equatorial or macular holes, which are trophic holes, be classified in stage B, since by definition they don't have edges and therefore cannot have reversed edges? The same goes for dialysis, who must have been confused with large tears. This is why we have only studied tears which are less confusing. The relation with failures seems obvious. However, given the small number of giant tears, 280, and to obtain better statistical strength, we have grouped the large tears and the giant tears. Thus, for a constant PVR stage and after removing the impact of aggravating factors, it can be seen, especially for stage B and C1, that the failure rate is statistically higher for large tears. Multivariate analysis confirmed that large tear is an independent explanatory variable of failure. Here too, confirmation of the correlation between the size of the tear and the blood-aqueous barrier breakdown found with the laser self-layer meter. As for the number of tears now, if we consider tears of normal size, no link could be highlighted. The number of tears could therefore not be individualized as an independent variable correlated with failure. In total, therefore, the multivariate study made it possible to individualize 4 variables independently linked to failures. Unfortunately, certain clinical details such as pupillary dilatation, vitreous turbidity, or the status of the posterior haloid could not be analyzed. But it is still the first time that clinical variables have been shown to statistically significantly influence the risk of failure. Now let's move on to surgical maneuvers, and first of external maneuvers. Here you have, depending on the stages, the failure caused by an indentation alone without associated vitrectomy. A buckling appears to be very suitable for stage 0A, for which there is a total failure rate of 0.5 and 1% retrospectively. On the other hand, for stage C1, a failure rate of 13% seems to demonstrate that isolated buckle without vitrectomy is probably not the appropriate procedure for this stage. In the absence of vitrectomy, it appears that retinopexy by cryotherapy gives better result than transpapillary photocoagulation, and that external drainage decreases the number of failures, but the results are not statistically significant. Now let's go to the influence of the vitrectomy machine parameters. I will not talk too much about gauges because at the time of the study the 27 gauge did not exist and the 25 gauge was just starting. On the other hand, there was already a quarter of the procedures made with aspiration flow control pump and 3/4 with machines equipped with a venturi pump. At first glance, it appears that the cases treated by machines equipped with aspiration flow control statistically cause less failure than machines equipped with venturi pump for both complete failures and cases where the silicone has not been removed. We see that this difference cannot be due to a difference in severity of the respective cases, even after removing the impact of aggravating factors. And if we compare stages by stages, the difference persists both in 20 gauge and in 23 gauge. A multivariate study taking into account the clinical details, the vitrectomy parameters and certain surgical maneuvers showed that the use of a venturi pump was responsible in this study for close to 3 times more complete failures with a significant statistical strength p equal 0.006. This discovery was enormous from 2 points of view. Firstly, because it is the first time that the study takes into account the parameters of surgical equipment, which testifies to its independence from the industry. But also imagine the effort you will have to make to get 3 times less lost eyes, 3 times less failures. Suppose that you have 12% failures in your first procedure detachment. How much effort will it take for you to go down to 4%? Well, a simple change of machine will allow you to make this step immediately. Now let's talk about the impact of some endocular maneuvers. For PVRB or C1, the peeling of the posterior haloid reduces the number of failures in a statistically significant manner. For PVR-C1, excluding the aggravating factors, the fact of carrying out a retinotomy increases the failure in a statistically significant way. Multivariate analysis finds retinotomy as an independent explanatory variable of failure rate. Surprisingly, during a vitrectomy, the fact of carrying out retinopexy by cryotherapy exposes to less failure than when a focal or 360 laser is performed, but the multivariate study found only the superiority of the cryotherapy compared to the focal laser treatment. At an equal PVR stage, after excluding aggravating factors, the use of gas during vitrectomy exposes to less failure than the use of silicone oil, and this is particularly true for stages C1. This was confirmed by the multivariate study regardless of stage. Multiple correspondence analysis was performed to see if there were groups of surgeons with common characteristics, depending on the vitrectomy machine used. A user of a machine that controls the aspiration flow will be more likely to use a slow cutting frequency, to inject more gas, and to perform more segmental buckle. A user of a machine equipped with a venturi pump will be more likely to use a high-speed cutting, to inject more silicone oil, and to perform more 360 circular buckle. Now let's finish with the strategy. In stage 0 or A, due to equatorial holes or small or normal sized tears, performing a vitrectomy exposes you to more failures. The p-value is not significant at the level of 5% for complete failures, but it is for cases where the silicone could not be removed. On the other hand, if the vitrectomy was carried out with a machine equipped with a venturi pump, at this time the difference becomes significant. A detachment 0 or A due to equatorial holes or small or normal tears without aggravating factors should therefore not undergo vitrectomy with a machine equipped with a venturi pump. I think that this can be interesting for some of us. Let us now consider the result of cryogas procedure. At first glance, for stage 0 or A, due to equatorial holes or tear of normal size, it is better to practice a buckling than to make a cryogas. However, the statistical analysis is not significant at a level of 5% for complete failures. In fact, If we consider only what are called retinogenic detachments, this is to say detachments due to equatorial holes, we can see that cryogas become an interesting procedure since it is sanctioned by no failures, but the limited number of cases, 33, means that the statistic is not significant. On the other hand, if now we only consider the detachments due to a normal tear, then cryogas is not recommended because the largest number of failures is statistically significant. When the stage becomes stage B, having a vitrectomy seems to cause fewer complete failures, but more cases where the silicone oil is not removed. As for tamponade, silicone oil injection does not seem to be recommended. Regarding PVRC1, the reduced number of cases will not allow significant results to be obtained, but we can immediately see that doing a vitrectomy with a flow control machine results in 4 to 5 times fewer complete failures than with a machine with a venturi pump, and 3 times fewer failures than without a vitrectomy. Again, silicone is not the tamponade of choice. When there is a choroidal detachment or large hypotonia, vitrectomy allows a significant reduction in complete failures. When the tear is large or giant, again, vitrectomy allows a highly significant reduction in complete failures, even after excluding aggravating factors. And this is true even if we consider stage A detachment, and even if you have a machine equipped with a venturi pump. Finally, in the event of a macular hole, vitrectomy is, of course, compulsory, and the injection of silicone oil is not recommended. And there again, we find the harmful side of the venturi pump, which leads to more complete failures and more persistent silicone oil. So you see, my friends, the result of this great study. These nearly 8,000 cases sent by 180 doctors from 48 countries who agreed to complete this huge questionnaire made it possible to build for the first time in the world a decision tree, very useful at least for beginners or surgeons in bad landmarks. As you can see, the surgical strategy must be adapted to the clinical findings. In the vast majority of stages 0 or A, performing a systematic vitrectomy will lead to a much higher number of failures than a simple buckling. It is also surprising to note that all the indications where one should not statistically make a vitrectomy are these cases where the laser cell flare meter reveals the rate of flare lower than 15 and a number of cells lower than 5, like if a proven hemato-ocular barrier breakdown was the best symptom encouraging for a vitrectomy. This is the case for choroidal detachment and major hypotonia, large or giant tear, paravascular tear, stage B and C, and, as we saw in the previous chapters, 13% of stage A marked by an unexplained hemato-ocular barrier breakdown, where a vitrectomy could prevent from 40% recurrence. The only problem of the RD study, as I have already told you, and as it is for each multicentric study, it is its lack of homogeneity in the performance of certain gestures, in the clinical finding analysis, and the fact that it does not take into account certain details such as vitreous turbidity, circumferential retinal fold, and the position of the posterior hyoid, which would further refine the strategy. This is what we will try to do by first analyzing how to diagnose these clinical details, so important to adapt a good strategy. Then, what are the therapeutic weapons that and their respective roles to fight against these clinical details? Then how to make these therapeutic roles exert, that is to say, how to carry out these surgical gestures which can influence the results. Then I will give you my surgical strategy, my personal strategy based on these personal statistics, which seems to give much better results than the EVRS RD study.